Welcome. Good morning. And thank you so much for being here with us to talk about an issue that is so important and frankly has been underaddressed in a lot of different areas of healthcare, which is how to take better care of pregnant and not and non-pregnant women in the emergency department, specifically through the lens of medication for addiction treatment and also reproductive care. I am so excited to introduce you to our speakers here in a hot minute. But first, in case you're new to us, we are the Bridge Center. We are a program underneath the Public Health Institute, and we started originally as just the California Bridge program doing some substance use treatment, but we since then have expanded our work to include reproductive care. We are very fortunate today that we also have some funding, not just from our typical funders, but from the RHSC Reproductive Health Corps and also TEACH, which is an organization that has been doing a lot of work with us to make reproductive care more accessible from the emergency department. So we're very grateful for our funders. You'll notice that all of our funders work in the public health space. They're all publicly funded. They're not pharma. So we still do not have any financial disclosures to offer you today. All of our speakers are going to be as unbiased and evidence-based as possible. But if we do say brand names, please forgive us. It's because in our clinical practice, we often say things like Narcan instead of naloxone or Suboxone instead of buprenorphine. But please know that that's not on purpose. We will try to say generics, but we might slip up from time to time. I did mention that originally we started off as the California Bridge program, and that's the one that people are most familiar with, our substance use disorder work. But since then, if you were to go to our website and you click our work, you'll see that we really have expanded. We do national work, we do EMS-based buprenorphine work, and now we also do a lot of work in the reproductive health space with our program Access Bridge. And then we also have a public health screening program that we call EDSP, Emergency Department Screening Program, thinking about screening for things like HIV and hepatitis C and syphilis for our patients who come to us in the emergency department, given the high rates of those public health issues that are happening in our communities and patients often not having access to care. What's really amazing about all these branches of our work at Bridge is that they all share this original foundation of the California Bridge model, which is number one, lowering the barrier to treatment, specifically medication treatment. And that is addiction care, that is reproductive care, that is even public health screening, right? We want people to be able to get the medications they need to treat the illnesses that they have with no barriers, with no extra paperwork, no extra visits, etc. But we also always honor that the role of the emergency department is resuscitation, stabilization, acute care, right? We are not long-term OBGYN providers. We are not long-term addiction providers. And so we want to really focus on smoothing out the connection from the emergency department into ongoing care in the community because that connection has been a big gap for a lot of our patients for a long time. And then finally, we believe in building a culture where the focus is on reducing harm, is on helping our patients live well. They're not always going to make the choices that we want, right? Like you're not going to make every teenager be abstinent and not have sex. You're not going to have every person in the world never use drugs. But we can do things like prevent unwanted pregnancy, prevent a sexually transmitted infection, prevent overdose death. There are lots of things we can do that help people live their best life and still have the agency to make their own choices. And that's a big focus for us. So, as we jump in to have this, multiple area, multidisciplinary conversation today, I am joined by three incredible, phenomenal female physician experts that I am so excited to have introduce themselves to you. I want to note before we do that we are about to cover a ton of information. Our goal together is to keep it very high level, to give you an introductory view into some of these topics. And we have a lot of resources on our website where you can deeper dive into all of them. So if it feels like we're going really fast and covering a lot, that's okay. Consider this webinar the outline for you of where you may do a deeper dive with our materials and with our other webinars. So I'm just really grateful to these women to be here today and help me have this conversation. I would love for each of you, please, to introduce yourself. Tell us who you are, where you live, and a brief summary of the work that you do, which is why I invited you here to be one of our speakers. Naz, let's go ahead and start with you.
Good morning, everyone. I'm Naz. I'm a OBGYN in Salinas, California. I'm also addiction medicine fellowship trained, and I'm happy to be here and talk to you guys about this problem.
Amazing. Emily. Emily, you're on mute. Sorry.
Sorry. Oh my gosh. Hi everyone. Good morning. My name's Emily Ager. I am an emergency physician in the San Francisco Bay Area, and I completed the Access Bridge fellowship last year, which was a wonderful experience and would recommend it to everyone who's interested. And I am a health services researcher, and my research focuses on ways to improve reproductive health in the emergency department setting specifically. And I'm very excited to talk with y'all about ways to make that possible.
And Jen.
Hi, everyone. I'm Jennifer Zhan. I am an emergency medicine and addiction medicine provider based in Los Angeles. I work for Bridge as the clinical implementation leader for the ED, syphilis, HIV, and hepatitis C screening program. I know many of your names already, and I'm honored to be here. Thank you.
Awesome. I am really just so excited to bring all of your expertise together for this talk today. So first, Naz, I'm going to put you in the hot seat. And just like how California Bridge got started originally doing substance use treatment care, I thought we could start by talking about treating specifically opioid use disorder in pregnant patients. This is a topic we have done a super deep dive on in the past, but I was hoping that we could maybe first understand what is the scope of this problem of opioid use disorder in pregnancy, and really important for everything that we talk about in the ED, like why is this an emergency department problem? Why are we really thinking about finding women who are pregnant and have opioid use disorder, and why is that a priority for us to identify and start that treatment?
Yeah, so it is becoming an issue, and I'm glad we're turning our attention to it. So 1 in 20 pregnant patients ages between 15 to 44 use illicit substances. And if we look at the ages between 15 to 17, this even rises and becomes 1 in 7. And also we are seeing the number of overdose associated death that has reached records highs. And the number of pregnant women who died from overdose nearly doubled between 2017 and 2020. And then if we add postpartum women to these group, we'll see the overdose mortality that has increased 81%. It peaked at 2020 with COVID-19 pandemic and is still going up. And this overdose is death associated with overdose is currently one of the leading causes of maternal death, and it's higher than preeclampsia, postpartum hemorrhage, which are the areas of focus on our L&D units. And also, based on a study that was published in JAMA in 2022, this rise in deaths are mainly associated with synthetic opioids and fentanyl. And also, if you look at when these deaths are happening for women, we see that the most vulnerable time is the late postpartum, 45 days to a year after delivery. And this is another chart that also reinforces that and shows that the postpartum death is highest. It does again decrease in third trimester, but increases in postpartum, and that can be because a lot of resources for our patients disappear after they finish their pregnancy.
Yeah, I mean, these numbers are very staggering to me. I'm a little bit shocked when I think about the rise of how many women are overdosing and are dying. Like that maternal mortality rate is extremely high, especially in a nation like ours where, we like to think that prenatal care is so accessible, but I know for any of us working in the ED, we're very aware that it's not, that we are often seeing women who have not had prenatal care, or, we're diagnosing women as pregnant. And we do see a lot of postpartum patients too. I mean, the fact that many women who, let's say, had Medicaid or Medi-Cal here in California during their pregnancy, right, it falls off for them and they don't have that continued ongoing care. So it's striking to me that the postpartum period ends up being a really big spike in overdose death. And that kind of makes sense that they're lost to the system. Like the baby gets care and mom really just gets forgotten. So if I put all those details together, I feel like I can reasonably deduce that there's like a critical and unique opportunity for us in the ED where we are seeing these women who otherwise kind of get missed by the healthcare system or dropped by the healthcare system. And so we have the chance to intervene and to make a difference with a treatment that's that's good for mom and for baby. So I appreciate you offering all of those
For sure.
details. And
Mhm.
one thing I'm thinking about when we think about treatment is that, especially for pregnant women, people get very worried about what medications are safe, what medications should be used.
Mhm.
And I'm wondering if you can speak a little bit to the methadone versus buprenorphine conversation. I know that both of them, we've covered many times in our webinars that both are very safe,
Mhm.
both are evidence-based, both save lives. But how should I be thinking
Mhm.
about those two medicines in pregnancy, and how do I know which one is right for a pregnant woman or a postpartum woman?
Yeah, for sure. That's a question that we always come across. And first and foremost, as you mentioned, both of them were life-saving and evidence-based for pregnancy. Ultimately, we should be using or choosing one for our patient that works the best for her. And if patient has a preference, then we'll just definitely go with that. But if they don't have a preference, there are a few reasons that we like buprenorphine better than methadone. And one is accessibility. Every clinician with DA license can prescribe it without any special certification or permission. In the past, known as ex-favor, that has gone away. But methadone requires a special certification dispensing, and buprenorphine can be given in ED, hospital, clinic, as a same day prescription. A lot of like every pharmacy has it now. And, when we look at the safety for the baby, some of the studies has shown that BU has a slightly lower rates of NAS and NOWS compared to methadone.
And
And
just to clarify, can you say
mm,
what NAS and NOWS, what does that stand for? What is that?
yeah, so neonatal withdrawal syndrome, and also for treatment of these conditions for the baby, we usually give them morphine. So, in these studies have shown that these babies need fewer doses of morphine and end up with a shorter hospital stay compared to methadone, which is a big win for both the patient. And also providers. But also, I just want to make sure that you guys know that both buprenorphine and methadone is way safer and has lower rates of NOWS in our babies compared to illicit drug use. And, it's at the end of the day, choose one that your patient will take and it's wanted by them.
So both methadone and buprenorphine proven to be safe, much better than illicit drugs for
Mhm.
both mom and for baby,
Yes.
stops overdose death, etc. But there are some benefits to baby in particular when it comes to using buprenorphine, such as less hospital stay, less need for morphine, treating those neonatal withdrawal symptoms.
Mhm.
We should emphasize that the whole eat, sleep, console movement has been really successful in treating a lot of these babies who get buprenorphine. They don't
Yes,
even need,
exactly.
yeah, they don't even need the morphine, which is great. And then, of course,
Hmm.
for mom, the convenience. I think that buprenorphine being more convenient can sometimes be the reason that we choose it. Okay, awesome. So we are not going to super deep dive into our buprenorphine quick start protocol. Anybody on this webinar looking for that, head to our website. We've got a whole half an hour dedicated to just that. But what I was hoping that you could do for us as an OB is, could you kind of overlay some of your thoughts onto our quick start protocol? Like when you're starting a patient on buprenorphine, specifically for a pregnant patient, what are things that we would want to know? Like what are
Hmm.
the points that you would want to think about while you're starting a mom on treatment specifically?
Yeah. So again, medication for opioid use disorder is very safe. Again, both buprenorphine and methadone has proven to decrease the mortality and overdose rates and save lives, right? Both mom and baby. And they're safe in pregnancy and also breastfeeding. And ACOG also came out with a committee opinion that also mentions that for pregnant women with an opioid use disorder, opioid agonist pharmacotherapy is recommended therapy, and it is preferred to medically supervised withdrawal because withdrawal is associated with high relapse rate, which lead to the worst outcome. And medication is just a standard of care. We don't want anybody to go, quote unquote, cold turkey. And here is a quick start. California Butte quick start for pregnancy is the same as and identical to starting any adult that is not pregnant on the Butte as well. And also, so with any of these protocols, we have to recognize withdrawal, which is usually cows a score of more than 8, and 1 to 2 objective findings, and you give 16 milligram of buprenorphine. And any formulation works, honestly. Buprenorphine, Suboxone, and also any injectable as well. And then patients might need higher doses, especially with in the fentanyl era, they have higher tolerance, or they're in 3rd trimester due to increased body mass and also metabolism. They might need way more than 16 milligram that you would start with. And, usually I do end up with the 32 milligram. One thing that we want to consider is the barriers, right? We want to, as providers, to not add any barriers and meet patients where they are at. So we don't need to admit these patients for fetal monitoring. We don't need to do labs, redox. It can be done in the ED, or we can actually give them prescription and instruction to do it at home, and is very, very safe. But another on the other side is if a mom wants to go through the start of the buprenorphine in the hospital without going through the withdrawal at home, it should be offered to them like any other patient we do. And it is a good option for this subset of patient. But then at the end of the day, no admission is needed for pregnant patients who are already in withdrawal to start buprenorphine, this life-saving medication. And then again, just like any non-pregnant protocol, we wait 30 to 45 minutes. We check the patient, see if they need more of the buprenorphine, and give more until they are feeling better, not in withdrawal. But if that's not happening, you're giving more, then we have to think of other diagnoses and widen our differentials, and think about alcohol withdrawal, DKA, and other things. And finally, discharge, prescribe buprenorphine. You can give at least 30 days of buprenorphine prescription. And usually, as I mentioned, patients usually end up with between 16 to 32 milligram per day. 24 milligram per day is the most common dose. But late in pregnancy, especially 3rd trimester, we also want to consider split dosing, 2 or 3 times of dosing per day, so they don't get withdrawal in the middle of the day. And think about increasing it later in pregnancy, just because the metabolism also increases. But also, it would be nice to have a warm handoff to outpatient care and to give them that long enough prescription to make sure that they can make it to their follow-up appointment and still have the medication.
So I want to highlight a couple of things that I heard you say, which is number one, the start looks very, very similar, or if not identical, to a patient that is not pregnant. We can use any formulation of bupe, the combo bupe naloxone, like Suboxone, for example, a long-acting injectable, the oral plain bupe, like any of these are acceptable and safe in pregnancy. I also heard you say we do not have to admit these patients. If she's already in withdrawal, you can quick start like everybody else. I know there are certain hospitals where, like right now, the standard is to admit for fetal monitoring. That's a wasted admission, a huge waste of
Yeah.
time and energy and healthcare costs. But for those of you who've been following along Bridge for a long time, we do have we call it like microdosing or cross tapering protocol, that if somebody's not in withdrawal and they don't want to go through withdrawal, there is a way to micro titrate up their bupe. And that would be a very reasonable reason to bring somebody into the hospital, just like we would any non-pregnant patient who wants to do that, because it's a bit more complicated. So option to admit for that, but for plain old bupe starts, that's just not necessary. But we do probably want to go up on our dosing, especially in the 3rd trimester. Don't be afraid of our normal 16, 24 milligram doses, and maybe even higher 32 milligrams in that 3rd trimester. Did I get all that right?
Yes,
Okay, cool.
yes. Thank
Perfect.
you.
So then I want to ask about then what happens when our patients go into labor, right? So maybe you started a patient on
Mhm.
bupe, they're in labor now, they come into the hospital. What should our labor and delivery colleagues know about what to do then? Or what if you're in a hospital where we don't have labor and delivery, and you have the unfortunate benefit of being an ER doc that's delivering a baby, and the patient was on, MOUD? What do you do in those cases?
Yeah, and we get that question a lot, and I love our ED colleagues for it, that they help us so much. So the main thing is to continue buprenorphine, like just continue it. This is their medication. Like if they came in with a high blood pressure medication, you would continue it. And you can increase the dose to help the pain control, or also split it to make sure that it provides the analgesia for the patient, and also helps them with the craving and withdrawal treatment as well. And then another thing is to use our non-opioids medications, such as epidural, multimodal, that protocols that you have in the hospital. And you can also give full opioid agonist on top of that, such as oxycodone. Don't be scared of that. And just treat their pain, listen to them. And then for postpartum, also, again, we talked about this. They're at high risk of relapse, and from the postpartum depression and all the complication that comes with this period. So the overdose mortality is at its highest during this period. So you want to make sure that they are connected to ongoing care outpatient, write the prescription for at the discharge until they get established with someone, or go back to their previous provider. And another thing is to tell them to come back into the ED if they're struggling getting any follow-up, or running out of medications.
I really love that. Remembering that the emergency department is the safety net, that, like, God forbid, mom has lost a follow-up, she can't access medication otherwise, that we're always here for her, that we in the ED should be an open door for mom to say, hey, you fell off of your bupe, let's continue it and redo that, navigation on to ongoing care, like we always emphasize. I really love that. Thank you for those details. Before we move on to our next topic, I will take a moment of personal privilege really quick to just say, the American College of Obstetrics and Gynecology, ACOG, which Dr. Naz referred to earlier, they also have a recommendation about universal screening for substance use in pregnancy. I want to just emphasize that in that case, when we talk about universal screening, we're talking about talking to our patients, asking patients about substance use, asking about alcohol use, having a conversation, starting treatment. We are not talking about urine toxicology testing. As a reminder, we've talked about this many times here as well, but that test is a bad test. It has really low rates of sensitivity and specificity for many drugs. It can trigger false positives. It can be a woman who, is trying to be in treatment, who comes to you in treatment. And if you were to do that urine toxicology screen, it would show positive for, let's say, fentanyl. And now she has a positive fentanyl test in her record, which in certain states and in certain areas triggers really significant downstream consequences to her ability to parent her child. So we do not want to penalize parents who are trying to get on medication, to be in treatment, to be a good parent. We want to support those parents, right? There's no such thing as tying the results of a urine toxicology test to somebody's ability to parent, or someone's ability to be pregnant, someone's ability to be healthy. Those things are not true. So make sure that you know your local laws. Here in California, we do not have to test in the emergency department. That is not true. So don't do it if you don't need it. If a patient tells you that they have substance use issues, believe them. They're normally not lying about that. And let's get our patients to the care that they need. So we just want to make sure that we emphasize that, and that those thoughts, by the way, are consistent with a 2011 committee opinion that was put out by ACOG that also really just supports identifying patients who have substance use so that we can help them get into treatment, not testing their urine so that they end up getting penalized when they were really just here trying to do the right thing. So I wanted to just emphasize that before we move on. And if you're interested in anything more about any of these, like, legalities of urine toxicology screening / testing, more information about, maternal opioid use disorder and how to treat that in more detail, we do have an hour-long, maternal fetal medicine style presentation about this on our Bridge Academy. So head there for that free CME if you're looking for it. All right. Jen, I'm not going to slide into putting you on the hot seat here because I want to talk about an actual screening, a different kind of definition of screening, because there are some screenings that we do, some tests that we do in the emergency department that can be genuinely beneficial and are evidence-based in helping specifically our pregnant and non-pregnant women to live happy and healthier lives. So I was hoping that you, Jen, could talk to us a little bit about the concept of public health related screenings from the emergency department and in general, how this can benefit our patients, whether they're pregnant yet, or they want to be pregnant, or they're not pregnant, and they don't want to be pregnant, any of our patients. And then also, as I asked Naz, how and why is the ED the right place to do some of this screening?
Great question. So one of the programs of Bridge is the ED syphilis HIV hepatitis C screening program. We have 28 grant-funded sites that are trialing universal opt-out ED screening for syphilis, HIV, and hepatitis C. These infections have been rising over the past decade, and we have an opportunity to intervene on them from the ED, right? Especially for pregnant patients where it's extra important, for these pregnant patients because the consequences of these infections is high for the mom and even higher for the baby. So the CDC recommends screening all pregnant patients for HIV, hepatitis B and C, and syphilis. Additional screening for pregnant patients include chlamydia and gonorrhea if they are at risk, and screening for BV, trichomonas, and HSV for symptomatic pregnant patients. So for pregnant patients that have established OB care, obviously they get their routine screenings outpatient and clinic. However, many patients do not have access to prenatal care or perhaps find out about their pregnancy in the ED when they visit for a different chief complaint, and they may have delayed OB care. So if you work in an ED, there's a tremendous amount of evidence to support universal opt-out screening for HIV, hepatitis, syphilis on all patients. And even if you're not able to do universal screening at your site, consider doing targeted screening on high-risk populations, including all pregnant patients.
So what I love about what you said is that this is an evidence-based practice, which I always appreciate. And I think again, nobody in the ED wants to hear that we're the answer to everything. I definitely am sensitive as an ED doc to asking us to solve all problems, but at the same time, this is a really high risk situation for especially for a pregnant woman, right? To have syphilis or to have HSV, to have hepatitis, right? That puts her pregnancy at risk and it puts the baby at risk. So if we want people to be able to have healthy pregnancies and deliveries, we should be supporting things like especially identifying for those high risk patients when they have those infections, and then we can help manage them. I will emphasize to all our navigators who are here, any of our clinicians who have navigators, this is another really good way to incorporate your navigator. I'm sensitive to the fact that our ED docs don't have a bunch of extra time floating around to like do a bunch of positive tests, callbacks, et cetera. So I do want to emphasize that we have to think about how we can make the system work for our patients without overburdening the clinician. But for any of my navigators, this might be a great project for you to talk to your clinicians about to figure out if you can offer that. So you mentioned a couple of different diseases, but you also mentioned the CDC, their recommendation about screening for syphilis. So I remember something about like an advisory that came out from the CDC or CDPH maybe last year. I think it was last year, telling us that we should be screening all pregnant women in the ED for syphilis in particular. I was wondering if you could maybe clarify for me what that was, and then also elaborate on why syphilis. Like, why is there such a huge emphasis right now on syphilis, and why should I be most concerned about that infection?
So you're absolutely right. So there was a bulletin recommending syphilis screening on all pregnant patients. And the reason being the rates of syphilis have just skyrocketed recently in the state. So rates in adults and adolescents rose by 131%. And the rates of congenital syphilis rose by 125% in just 2 years. So congenital syphilis has increased tenfold in the past decade. And California is the sixth highest state with congenital syphilis. Why is this so critical to identify? Congenital syphilis is syphilis contracted by the fetus in the uterus. And if you guys remember, for med school, they teach us that syphilis is the great imitator or the mask killer because it could just stay dormant in your system forever and cause these insidious symptoms. For newborns, 2/3 of them are born without symptoms initially and can develop them in the first few years of life. And for the other pregnancies, it can lead to miscarriage, prematurity, stillbirth, and death. So congenital syphilis is usually divided into early and late symptoms. Early symptoms happen from birth to the first few years, and they include an enlarged liver and enlarged spleen, which is a hepatosplenomegaly. And this all happens because the white blood cells of the baby and the mom are trying to attack the spirochetes of syphilis. It can cause a maculopapular rash, often involving the palms and soles, and it can cause pneumonia, which is really dangerous for babies with underdeveloped lungs. Late syphilis happens after the first few years, and same concept, it's the white blood cells trying to fight these spirochetes that cause inflammation. When it happens in the nasal cartilage, it can cause a saddle nose deformity. When it happens in the bones, it can cause a saber shin deformity in the tibia. It can lead to Hutchinson's triad, if you guys remember that from step one. So Hutchinson's teeth is, when they get notches to the central incisors of their teeth, it can cause interstitial keratitis that causes blindness, and it can attack the internal auditory nerve that causes deafness. So really devastating consequences for these babies, and it's important to identify and treat them as early as possible in pregnancy.
Yeah, and I'm also remembering a lot more about syphilis than I thought I even remembered. But with particular emphasis, right, being placed on we can carry it for so long and not even know we have it. And then in pregnancy, if that were to be reactivated, it would be just so consequential, both for mother, but also for that baby with things like pneumonia can lead to miscarriage, can lead to pregnancy loss in general. So certainly a population that we want to emphasize testing for. And I just want to clarify that I had a chance to glance at it while you were talking, but thank you for that link in the chat that CDPH is the one that put out some updates about it. And that in that update, it recommended that if you are an emergency provider and you're seeing a pregnant patient, if you do not have physical access to a syphilis screening test from that pregnancy, so like where I work, my computer is not connected to my local community clinicians, that you should still test. And there's like, no, it's fine. Double test, triple test, who cares? Unless you can see that result from this pregnancy, we should be screening our patients for syphilis. That's definitely something that I plan to add to my practice because I'm hearing just again, how consequential it is. And it's only one test. I don't see that many pregnant patients, overall who are going to test positive. So worth doing it. But that does bring me to a question, which is, if I am doing these screenings, if I'm screening for HIV, especially if I'm, screening for hepatitis, what do I do if they test positive? Like, the STIs, that one I'm good with. I know how to treat gonorrhea and chlamydia, and I can look that up pretty easily, even syphilis, I guess. But could you briefly kind of summarize what does treatment look like for pregnant patients? And then if I want more information, how do I figure out, like, where is that? Where's your best recommended information that I can use for what to do when I have a positive test?
Absolutely. On our website, there is a link to the EDSP program where we have a ton of free resources. So go to our work, and then on the right, under public health screening, click ED, syphilis, HIV, Hep C screening, and scroll down, and there's a resources on the left side after you get to that page. We have a ton of free access resources for ED care. So there's test to treat protocols for these disease processes. There's patient education handouts for how to explain to the patient what a positive test means. I will say that these protocols are for the general population. And in pregnancy, treatment often looks the same. So for syphilis, the treatment is IM penicillin G. And depending on whether it's early latent syphilis versus unknown length of duration or late syphilis, they will either need one shot in early or 3 shots 1 week apart each in late syphilis. For pregnant patients who are allergic to penicillin, unfortunately, doxycycline, the alternative treatment, is not recommended in pregnancy. So the recommendation is for these patients to go through a desensitization process so that they can receive IM penicillin, which is the recommended treatment. And for HIV, so our protocol focuses on treating the general population. For pregnant patients, the treatment is dolutegravir regimens. So usually dolutegravir plus TAF/FTC. It's really long names. I don't need to explain it in detail, but check out our protocol, and the dosing and stuff is on there. So for HIV, the vertical transmission rate to a baby is 15 to 45% without treatment. And if the mom is treated, then that transmission risk is reduced to less than 2%, and it really improves fetal outcomes. So super important to identify and treat early in pregnancy. For hepatitis C, the antiviral therapy is deferred until postpartum. There's just not enough studies to test for the safety of an 8-week or 12-week course of antiviral therapy for HCV in pregnancy yet. So the vertical transmission rate is about 5 to 6% for hepatitis C. Regardless, yeah, we recommend that you test your patients, especially the high risk ones that have poor access to care, and take an opportunity to treat them when possible, because you're not just saving one, but potentially 2 lives.
Awesome. I'm so glad those protocols exist. I don't have to memorize all of the things that you just said, but now at least I know where I can go to find them. And I appreciate the distinction that most of these are going to be the same for pregnant patients as they are for non-pregnant patients, minus the doxycycline clarification, and then especially the deferral of hepatitis C treatment until after pregnancy. Really helpful and super high yield. All right. I want to shift now and talk about perhaps the most common complication, if you will, in pregnancy, that at least that we see in the emergency department, which is actually miscarriage or early pregnancy loss. We use the term early pregnancy loss because from our perspective in the emergency department, it really doesn't matter what caused a woman to start to lose her pregnancy. It could be a spontaneous miscarriage. She may have started a medication abortion. It does not really matter. But the point is, when the fetus is not viable and the woman comes in with bleeding or cramping, right, we are looking at early pregnancy loss. And we see that every single shift, sometimes multiple times in that shift. I know that in my training, and I went to a very, very good, maybe the best residency program that exists over here in emergency medicine, but really the only option that I was trained about though was expectant management. And I went to a really, really good program. And I'm a little bit embarrassed to admit that until I started doing work with Access Bridge in the past year or two, I didn't even know that other options existed. That like expectant management, offering some verbal support, saying, I'm so sorry for your loss, encouraging that woman that it wasn't her fault, et cetera, and like giving some, acetaminophen and some NSAIDs and some nausea medicine. Like that's really the only way that I knew. So, Emily, you are an emergency physician and also a reproductive healthcare champion in the ED, doing this work every day in the pit, next to me or next to whoever on shift. I would love for you to walk us through what are actually the options for early pregnancy loss that we need to know about as emergency clinicians. And then hopefully you can kind of walk through each of them with us and talk to us about what we have to know and how to counsel patients about those options.
Yeah, absolutely. And that was a great introduction to the context of this problem overall, is that I think our emergency medicine training instills in us that there's only one option for helping patients with a miscarriage, but in reality, there are 3 options that we can offer to patients. And it's so important that patients are aware of all of these options. So as you said, the first option is expectant management. The second is medication-based management, and the third is procedural management. So I can walk through each of those in a little more detail. For expectant management, we essentially mean a watch and wait approach where there's really no intervention that we're offering to patients. It's kind of the things that you said: supportive counseling, medications for symptom management, and then eventual follow-up with their primary obstetric provider to make sure that their symptoms are being managed and they have all the knowledge and resources that they need. And essentially the products of conception are allowed to pass naturally on their own without intervention. The second main approach is medication-based management. And here you can see our wonderful Access Bridge protocol for providing medication management. And this approach uses 2 medications to assist the body in passing the products of conception more efficiently. So the first medication that we use is called mifepristone. This medication is used for both abortion care and miscarriage care. And so there is a lot of stigma and unnecessary restrictions around the medication, which I'll touch on in a little bit. But basically, mifepristone works by blocking the progesterone receptors in the body, which then helps to stop a pregnancy from growing. And then the medication also softens the cervix and then helps the uterus, the lining of the uterus, break down. And so in this way, it's more easy for the body to pass the products of conception out of the uterus and expedite the process of resolving a miscarriage. And the second medication involved in medication management of early pregnancy loss is misoprostol. There's a lot of M medications here, so there's some tongue twisters. But misoprostol works by inducing uterine contractions to then help expel the pregnancy tissue. And the misoprostol is given after the mifepristone. So the two medications work in tandem to help, again, expedite the pregnancy loss resolution. We have great evidence at this point in 2025 that the combination regimen of mifepristone followed by misoprostol is the most effective medication regimen. Again, because Miffy ripens and softens the cervix, and then misoprostol helps the uterus contract to help pass the products out of the uterus. Like I mentioned before, there's a lot of stigma around Miffy because it is also the medication used for abortion care. And so there's in part because of that, there's some extra red tape and bureaucracy around mifepristone, which is primarily comes from the FDA's. It's called a REMS restrictions, and so the REMS program for mifepristone kind of restricts how clinicians are able to use the medication and in what settings. And so, and we'll touch on that a little bit more later. But just to know that despite all of that stigma and extra red tape, Miffy is an extremely safe and effective medication. And so if you do want help getting this medicine on formulary, if you don't already, please reach out to the Bridge team because there are so many resources and people who are very excited to help you get this medication in your hospital. And so I also want to say that if Miffy is not available for, whatever reason, that there are safe misoprostol only approaches for treating early pregnancy loss. And in some contexts, it may be the only reasonable and actually available option. And so you can use a miso only protocol for the medication management for early pregnancy loss. And this is still safe and supported by ACOG as well as a viable option for this approach. And so where I work, we've followed these Access Bridge protocols or have protocols that are adapted directly from the Bridge website. They're very easy to follow and tell clinicians everything they need to know about these medications and how to administer them to patients, which can be extremely helpful if you are in a setting where maybe you aren't seeing patients, with miscarriage or early pregnancy loss every single shift. Okay, and then the third and final approach for managing a miscarriage, like I mentioned, is a procedural approach. This involves a clinician assisting to actually remove the products of conception from the uterus, either by vacuum suction, which we call manual uterine aspiration or MUA, or by entering the uterus and manually removing the products. This would be the dilation and evacuation, or a D&E. People are moving away from using the term dilation and curettage, or D&C, because curettage is not really used anymore for this procedure. In general, patient autonomy, in terms of choosing which approach for a patient or helping a patient choose which approach, patient autonomy is truly of the utmost importance. And for the majority of clinical situations, all options are safe and effective for patients. But because pregnancy loss is such a preference-sensitive condition, it's really our job to help patients have the knowledge for all these options and for them to be able to make the choice. And as you mentioned, most ED teams assume that a patient will receive expectant management, or that is what they want, unless somebody has like life-threatening bleeding or is hemorrhaging. But really, like at this point in 2025, that's not good enough for our patients, and our patients have a right to this information and to be able to make their own choice. And then as a kind of final note, that a lot of patients have miscarriages in the US, and actually 1 in 5 of all recognized pregnancies in the US actually end in early pregnancy loss. There's obviously a lot more that do that aren't recognized pregnancy. And a lot of patients don't seek medical care when they have early pregnancy loss. And so the patients who are coming to the ED for this care are there for a reason. A lot of patients, like I said, never, access the medical system when this happens. And so they come to the ED because for, like a lot of other conditions, they don't have established or accessible OB or primary care. Or in severe situations, they're having vaginal bleeding, severe abdominal pain or cramping. And so I think that's just another thing to keep in mind is that when the patients come to the ED for this care, we really need to embrace this opportunity to offer patients all the options and help counsel them to select the one that's right for their particular situation.
I want to jump in here and emphasize what you just said because I think it's really poignant that while we think seeing miscarriage in the ED is a commonplace everyday thing that we do, we are actually not even coming close to seeing the majority of patients having early pregnancy loss. Like not even close. Most of them don't actually come to the ER. So the ones that do need something. Either they're having a more painful, further along or more hemorrhaging type of experience, or it's a patient that does not have the ability to get outpatient care in a different way. And so realizing that it really is our responsibility to know about expectant management, medication management, whether it's with Miffy and Meso, or if you only have misoprostol available, which our clinical director for the Access Bridge program is here in the chat, and she emphasized this that I really appreciate, which is even the misoprostol only protocols are actually far more effective at expediting the management of early pregnancy loss compared to expectant alone. So there's still a benefit even if you don't have Miffy, but that the idea that these patients are just having a miscarriage, expectant and go is not actually the right mindset, right? These are patients that don't have other care. We are their care, or they are having a more complicated early pregnancy loss than typical. And so we really should give ourselves a moment to pause and think about those options. I'm wondering if I am going to counsel patients about it and I want to think about the differences, like an easy way to break down how to talk to a patient about, let's say, costs or is it painful or what to expect. Like, can you walk through kind of how you would compare each of those three options with a patient?
Yeah, absolutely. There are several factors that are the most common kind of areas where patients make the decision about which option is best for them, which we have outlined here. So the first is symptom duration, and I'll just sort of start with expectant management. So for expectant management, patients can have ongoing symptoms for up to 4 weeks, so a month of bleeding and cramping, which for some patients is acceptable, and for others they need to get on with their lives, and that's not really an option for them. There's no cost for expectant management, which may be preferable for some patients. In terms of the pain that patient experience, it can be little to no pain, more like severe period cramping, which may be acceptable again to some patients. And the location is that this can happen at home and doesn't necessarily require subsequent interactions with the healthcare system, which patients may prefer. For medication management, as you said, even with misoprostol alone, and especially with meso and mifepristone, the duration of symptoms, it's much shorter. It's about 7 to 8 days. The cost is still quite low. These medications are really not that expensive. And in terms of symptoms, because misoprostol does cause uterine contraction, patients can have a more painful experience with taking these medications, and they can have severe cramping for up to 8 hours. As long as patients need to know this possibility, and if that's acceptable to them, then the main thing that we can do is to send patients home with prescriptions for medications to manage these symptoms, like PO ketorolac, which we recommend 10 milligrams every eight hours, as well as Tylenol scheduled together, taken around the clock. And then you can prescribe patients opioid medications as needed for 2 days maximum for severe pain, not controlled by ketorolac or Tylenol, acetaminophen. And, as based on the topics we've been talking throughout this webinar, it is very important to still screen patients for substance use disorder and taking into account those opioid prescriptions from a safety perspective, as we always do. And then also coaching the patients to take those pain medications immediately after they take the Miffy and Meso so that they're sort of on top of controlling those symptoms. And then finally, for the location, patients will be in the ED, and then again, they can be at home in a private setting, which some patients may prefer. Lastly, for procedural management, in terms of the symptom duration, this is the shortest. The procedure is performed, and on the same day, they have resolution of symptoms. It is of higher cost. The cost can vary depending on insurance coverage. I think most estimates I've seen are between $600 to $1,000. Again, can be fully covered or variable depending on insurance coverage and hospital setting. This is performed in, the pain experience, so very mild post-procedural pain, no real significant pain with the procedure. It can be done with PO pain medications like ketorolac and acetaminophen, though for patients who may need more, sedation, conscious sedation medications, that's also an option as well for patients. And the location, so it does happen in the hospital, and some patients, may not want to have this care in a clinical setting, and for others, that's acceptable. And then just a final note, the MUA or manual uterine aspiration that I mentioned before, that can be done in the emergency department by ED clinicians. That is an option that I think is common in some settings and has some growing support among the emergency medicine community once EM clinicians are trained in that care. Otherwise, it can be provided by our OB colleagues. And then, like I mentioned before, the dilation and evacuation, or D&E, is only performed by OB clinicians.
I do want to emphasize one thing that I heard you say about when we're doing medication-based, in particular with the misoprostol, that it does cause severe pain. And I just want to kind of give a nod that if we, the people at Bridge, who are like treating opioid use disorder as a huge priority for us, if we are sitting here saying it is so painful it can require opioids, oh, people, please treat the pain for these women. I think it's very common for us to be so afraid about prescribing opioids. I think maybe cautious and conscientious are the right words because that's appropriate. We have a long history of understanding the consequences, but pregnancy loss can be really painful. And women historically have been told, go home, tolerate it, it'll resolve on its own. That's just not the right answer. To let every pregnant person know that they do have options. I'm thinking about a lot of my patients who are literally like migrant farm workers who do not have 7 to 8 days or 4 weeks to like be bleeding. They're going to go back to work, these women. They're going to like suffer at work, bleeding into an adult diaper. And if I can think about how to implement MUA, like the vacuum aspiration in my emergency department, what an amazing service I could offer to these women to help them get back into their regular flow of life and not have to experience that for such a long time, really relieving pain and suffering, which is what we all kind of set out to do. So I just want to emphasize some of those big points, that some of these processes can be really painful, and we should honor that in our patients. The first couple of days can be really painful, and treat that the way that you would for someone with a kidney stone, the way you would for someone with a broken bone. And then thinking about what is really best for this patient's overall health, and not just, oh, it'll be fine. For me, it's an easy ED visit. That's not the right answer. Is how do we make it best for that patient? So I really appreciate all of that information. I will also mention that while we do not have deep dives into these items on our Bridge website, we do have some amazing friends with an organization called FemInM, which EM, Femin EM, Emergency Medicine, who have a deep dive free CME into each of these protocols. They review our Access Bridge protocols in their lectures. I highly encourage you to seek those if you're a clinician looking for more, and you can find those at courses.feminm, so FEMINEM.org. Courses.feminine.org. We love that they put those together. They're amazing educators. They do a really good job, and they'll review our protocols in more depth for you. So thank you, Emily, for that. Last topic in our last couple of minutes here, and we won't linger on it too long, but you did mention that the way that mifepristone or Miffy and misoprostol or Meso, that those two medicines work to help relieve early pregnancy loss, really is the same way that they work to induce a medication abortion. So different starting point, but same processes going forward. And I will highlight that you are currently working at one of maybe 2 or 3 that we know of so far as of today in 2025, hospitals in California that are actually doing medication abortion from the emergency department. We know that access to abortion care is extremely limited. And as with any new treatment or procedure that we talk about in the emergency department, I think it's important for us to pause and think about why medication abortion access from the ED would be appropriate in specific settings. And then also, again, just with the idea that we are not supposed to be the answer to every problem in healthcare, but clearly the medicine for this is something that we can do because we can do it for early pregnancy loss. Can you make the quick case for me why a hospital or an ED clinician might consider starting medication abortion from the ER as an option for their patients?
Yeah, absolutely. So I think anyone who has been in emergency medicine for the last 10 years would know is that we are truly the safety net of the healthcare system. And I think this is a position that we all pride ourselves on and is probably a core reason of why we chose this specialty. And so we know that patients really struggle with access to care for a variety of medical conditions, and especially those who need it most are at the most at risk of certain conditions are the ones who struggle with accessing that care the most. Um, and we recognize in our patients that even patients with really great private insurance can still struggle with timely access to care. And for the conditions that we're talking about, seeing a primary clinician or an OB clinician, 3 months out, can not be acceptable for conditions like being pregnant when it's not wanted. And so when for patients have an unwanted pregnancy, they often need more timely care that may be offered in their healthcare system. And 3 months is, not a reasonable time to wait for an appointment. And so this is a really time sensitive condition. And, another obvious context is in states with abortion restrictions that, have a certain gestational duration. And past that point, abortion is no longer an option. So I think that's my pitch is that emergency departments can really meet the needs of patients who are facing those barriers.
So what I'm hearing you say is not only do we have areas of our state, even in our country, where abortion access is limited, but you also have many states where it's extremely time sensitive, right? After 6 weeks, after 8 weeks, after whatever weeks, you can't even have an abortion. And if we ask women to follow up outpatient, it may not actually happen in time. So it is very time sensitive. We are taking away somebody's opportunity. And I mean, I put our protocol up here on the slide. You'll notice it's very, very medically simple. We won't deep dive into it today because we don't really have the time, but it's really the same medicines, just dosed a little bit differently. And so if you're interested in that, there is some paperwork that Emily mentioned earlier, the REMS paperwork, the FDA paperwork that you do have to fill out, but it's not actually that complicated. So if you do want help doing that, I would really just emphasize that we here, the team at Bridge, we are really here to help you. So if you want us to help you figure that out or to navigate through that, please reach out to us individually. It may not be right at every hospital. Maybe your hospital is a Catholic hospital. Maybe you live in a state where it's actually illegal. Like, we're not asking you to break the law. But if you're in a place like California where we can improve that access to care, but our patients still struggle with the timeliness feature, sometimes the ED is going to be the only option or the right option for that patient, given transportation, accessibility, insurance issues, et cetera. So if you're interested, reach out to us and we'd love to help you make that happen. All right. We covered a gigantic Herculean level of information today. We tried to do our best at giving enough detail, but if you want more, we have more. So please reach out to us or visit our website for any of those resources that we mentioned. By means of a very brief recap. First, Dr. Naz talked to us about MOUD, medication for opioid use disorder in pregnancy. And the important things there were it saves lives. It's safe for mom, it's safe for baby, it's safe during pregnancy, and it's safe during the breastfeeding period. And also, really big emphasis, mom needs to stay on medicine. Don't let her get lost to the system. Use the emergency department as a backup if you have to get her back on that prescription and continuing that medication going forward so she can be the best parent that she wants to be. And also, it's really important to remember that the doses, right? 16, 24 milligrams a day, very normal, maybe even higher, 32 milligrams during that third trimester. And some moms during third trimester will need to split it up into multiple, like divided daily doses just because of the way that her metabolism works. That might work better for for her. Do not stop the medication during labor, but also don't be afraid to give other medicines around it. Use that epidural, use, acetaminophen, use opioids, give morphine, give hydromorphone, give whatever you need to control mom's pain during labor. It is safe and it is okay. Please beware of the urine toxicology testing. Only use it in appropriate settings. Make sure you know the actual laws in your area and those downstream consequences, and don't use it if you don't need it. Talk to your patient. That's much more accurate than this test that has a horrible sensitivity and specificity. We then talked to Dr. Zhan about all of the, high risk public health infections that are currently out there and just how crucial it is for us to think about screening, especially pregnant women for those, in particular syphilis. I certainly know that for me, that's practice changing. I'm going to now be screening every single pregnant patient I see in the ED with syphilis, unless I have a copy of a test from this pregnancy proving that she's already been screened. And then if you're looking for what to do, how to manage those infections, should you get a positive test, or if you want more information about implementing an opt-out universal screening from your emergency department, head to our website and see that EDSP program and all of their resources. When you see a patient experiencing early pregnancy loss, she has options. Make sure you know what those options are and how to talk to her about it. Expectant is only one option, but you could use mifepristone and misoprostol or misoprostol alone to make it a much more effective expulsion of the products of conception to help mom get back to her regular life faster and not have to bleed for 4 to 6 weeks at a time. And then make sure that you know how to get moms access to procedural care if they do need it. So she needs a vacuum aspiration and you don't have that ability, or she needs a dilation and evacuation, which will happen sometimes when it doesn't progress normally. Make sure we know how to get those patients that care that they need. And then finally, maternity care deserts are a real thing. We are doing a ton of this from the ED, especially as we see more and more OBGYN services and labor and delivery units close across our state in California, across the nation. So make sure that you're thinking about how to ensure that moms, that pregnant women have access to the care that they need when they need it. And in some settings, that's going to include access to medication abortion. If you're more interested in figuring out how to do that, filling out the REMS criteria, paperwork, etc., please don't be afraid to reach out to us. We love to help anybody get through any of it. And we have everything that you could possibly need available to you on our website. It is free. Visit us at bridge2treatment.org to see copies of all of that. If you are looking for a deeper dive on any of these topics or anything else, buprenorphine, opioid, drug-related in general, head to our free CME Academy with California Bridge. We have a specific academy for clinicians, one for nurses, and one for navigators, all of which come with CMEs or CEUs for our navigators. And it is free, always, and no financial disclosures across any of our lectures. It's all public health funded, and we're really happy to provide that as a service to you. And I mentioned this, but we mean it. If you need us, info@bridge2treatment.org. info@bridge2treatment.org. We have real human beings that actually answer that email, and we're super excited to, hear from you at any time. I want to first offer a big thank you to our speakers, everyone, virtual round of applause. Thank you for giving us your expertise and just for showing us how we can implement evidence-based, simple protocols that improve care for pregnant and non-pregnant women in the emergency department, a population that often gets, underserviced and underthought about in a lot of categories. So thank you for helping us to do better. And what I also just want to end by saying, as I do always, but for the rest of you, thank you for taking your time and taking the initiative to join us today and to enter this conversation and to think about how you might update your practice and your clinical setting to do better for these patients. And as always, thank you for everything that you are doing to help us save lives. Have a great day.